Hi, my name is Brianna Charis, and I'm Associate Editor of Managed Healthcare Executive.
Hello, my name is Peter Werwine, and I am Senior Editor of Managed Healthcare Executive.
Today, we have the pleasure of speaking with Keely Macmillan, Senior Vice President of Policy and Solutions Management at Archway Health, a healthcare consulting firm in Boston. Very few people on this planet know as much about value-based care, payment models, and ACOs than Keely. So listen in and learn a lot. Thanks for your time today, Keely.
Thanks very much, Brianna. Great to be with you and Peter today.
So today we're talking about the Value in Healthcare Act of 2020, which would make some important changes to the Medicare Shared Saving Programs, or MSSP ACOs, which is the largest CMS ACO program.
There's a concern that something like COVID-19 might deter providers from participating in these programs, including MSSP. And CMS really wants to avoid providers dropping out of these programs and actually wants to encourage participation because they've found that providers who are participating in programs like MSSP are better equipped to provide high quality care for their patient population, even during a public health emergency. And so this bipartisan bill really aims to support participants in the program and support the move to value-based care. And as part of that, extending the runway for providers to be in upside-only arrangements is one way to do that. There's also a lot of other important pieces of that bill, including an extension of the advanced APM bonus, as well as modifying or reducing the thresholds that providers would need to hit in order to qualify for a 5% bonus under the advanced APM track under MACRA. So extending the time period for MSSP programs to stay in upside-only arrangement is only one piece of a number of legislative priorities that are part of that act. So I don't know that it's meant to counter the pathways to success, but rather facilitate greater participation in the long run in programs like MSSP.
And I think the two provisions that might accelerate participation, one would, I believe, the pathways to success lowers the share savings threshold to 40%, and I think the act would increase that to 50%. I think also doesn't it allow for 3 years of upside risk only?
Yep, that's correct. That's correct.
And in terms of the APM adjustments, there's a lot of numbers here, but I believe that if the APM was sort of left to be unchanged, the bonuses that participating practices would earn would drop from 5% to 0.75%, and the value, this legislation would keep it at 5% for about 6 years. And I think it also changes the thresholds which practices need to meet, correct?
Yeah, there are a bunch of different thresholds and adjustments that are going on. When MACRA was passed, they did a number of things. It set the incremental increase as far as baseline payment, your baseline payment rates. Ultimately, inflation, they set that at 0.5 and 0.25 and 0.75, depending on which track you're in. That's one piece of this. I think the bigger piece of this is that they're modifying the thresholds that would be required to become a qualified participant, or QP. If you become a qualified participant or QP, you can receive a 5% bonus on all of your Medicare Part B professional service revenue. So this is a 5% bonus for all of your Medicare fee-for-service patients. And to do that, you have to have, and these thresholds have been increasing, but currently clinicians have to have at least 50% of their Medicare Part B professional service revenue tied to an advanced alternative payment model. And that's already a difficult threshold to hit. And that threshold is set to increase to 75%, which is essentially impossible for a vast majority of clinicians. And so this bill would lower that 75% threshold back down to 50% and allow the Secretary of HHS to increase that by a maximum of 5% each year. So it would certainly slow the increase of that threshold that would be required to get that bonus. And MACRA had only put in place that 5% bonus through a certain number of years. This Value Act would extend the duration of that 5% bonus for an additional 6 years through performance year 2028, which translates to payment year 2030. So extends the runway for providers to earn this 5% bonus.
Again, this seems like it might have the consequence of slowing down adoption of value-based care models and alternative payment models. I mean, the whole thrust and the reason for the cranking up of the thresholds is to force the issue in some sense, rather than have people sort of hedge their bet or keep, so is that do you accept that point as that legitimate critique?
Well, I think it's important to keep in mind what's also going on in parallel with this act in Congress is what's going on with CMS and their launching of a bunch of new alternative payment models. I think, COVID-19 in many ways makes some of these alternative payment models more attractive in that some of these alternative payment models that CMS is rolling out have prospective capitated or semi-capitated payment arrangements, which historically have, there's been low adoption of, but with COVID-19 and providers seeing their fee-for-service revenue drop significantly with all of these elective procedures and office visits going away or being postponed, providers in capitated or semi-capitated payment arrangements that had these predetermined amounts to care for their patients, they actually were faring much better during this public health emergency and were financially better equipped to continue to provide care for their patients and implement telehealth and weren't forced to furlough their staff like many providers who are reliant on fee-for-service revenue. So this alternative payment mechanism in which providers are receiving revenue that's not directly tied to volume, but rather providing services for a population of patients might become more attractive should something like COVID-19 happen again, or we have another wave. Providers would not be as reliant on that fee-for-service reimbursement. So that might actually draw greater adoption of these models where there's a more reliable revenue stream, especially during something like a pandemic. So I think a combination of a more reliable revenue stream through these models, as well as reformed legislation that allows providers to stay in upside only for a little bit longer, allows providers to collect a 5% bonus for an additional 6 years, in which it's those thresholds are not as challenging to hit to get that 5% bonus. I think these are all reasons providers might actually move towards participating in these models. Another thing to think about is whether they were ready or not, COVID-19 forced providers to adopt innovative ways to deliver care more efficiently. Certainly telehealth is a prime example. Other examples include remote patient monitoring and remote patient engagement. And having 24/7 phone lines set up. A lot of this infrastructure that providers were forced to adopt in the face of COVID now might actually service them very well in an alternative payment model. And so in a way, participating in one of these models could be a way for them to cash in on some of the investments, so to speak, that they were forced to put in place in COVID. These investments should allow them to better coordinate care for their patients and manage patients with chronic conditions which should lead, if done correctly and if done effectively, should lead to lower overall spending. And so, having been forced to put in this infrastructure might be a reason for providers to participate in these models, because that will well align with the performance-based payments of these programs.